Good evening, everyone, and welcome to tonight's presentation by the Scleral Lens Education Society, entitled the 2018 Publication and Research Update on Scleral Lenses. So tonight's presenters are Dr. Muriel Schornack and Dr. Mindy Toabe. Dr. Schornack received her Bachelor's of Arts degree in organ performance from Jamestown College in 1984, followed by a Master's of Music degree in piano Pediology from University of Illinois. Thank you. From University of Illinois at Urbana-Champaign in 1987. She worked as an arts administrator and piano instructor for several years before beginning to pursue her optometry degree in 1994. She attended the Illinois College of Optometry and received a valedictorian award upon graduation in 1998. She then completed a residency in primary eye care at Illinois Eye Institute. Dr. Schornack joined the ophthalmology department at Mayo Clinic in Rochester, Minnesota upon completing her residency in 1998. She now serves as a consultant in that department and holds the rank of assistant professor in the Mayo Clinic College of Medicine. She was instrumental in the development of the Mayo Community Eye Care Clinic and served as a medical director of that clinic from its inception in 2004 until 2012. She's also responsible for the development of the Mayo Clinic Scleral Lens program in 2006. Since the inception of the Mayo Scleral Lens Clinic, Dr. Schornack has lectured, presented, and published regularly on the topic of scleral lenses. She is currently a member of the editorial board of Eye and Contact Lens and regularly reviews manuscripts for a number of optometric and ophthalmologic journals. She is a founding member of the Scleral Lens Education Society and currently serves on the advisory board for the organization. She's also a founding member of the SCOPE study team and still actively involved in that group's research activities. Our other presenter, Dr. Toabe, is a hospital-based optometrist in a multidisciplinary setting with a specialty in medical contact lens, practicing at Metro Health Medical Center within the Department of Surgery, Division of Ophthalmology in Cleveland, Ohio. She's a senior clinical instructor at Case Western Reserve University School of Medicine, while also working with ophthalmology residents at the Cleveland Clinic, Cole Eye Institute. Additionally, she is adjunct faculty at The Ohio State University College of Optometry. Dr. Toabe is the immediate past president and a founding board member of the Scleral Lens Education Society. She is a full member and serves on the council for the International Society of Contact Lenses. She is also on the advisory board for the Gasperville Lens Institute. She has lectured both nationally and internationally, as well as published numerous articles about specialty contact lenses, including scleral lenses. Her main areas of clinical research interest are primary care, ocular disease, dry eye management, specialty medical contact lenses, and dry eye and contact lenses. And so with that, I will turn it over to Dr. Schornack.
Well, good evening, everyone. First of all, our disclosure slide, neither Dr. Toabe nor myself has any disclosures to announce. So we have a couple of objectives for the next hour or so here. First of all, we're going to talk about some of the study designs that are being used to report scleral lens outcomes in peer-reviewed literature. Secondly, we're going to review current literature regarding scleral lens prescription and management. We're going to discuss emerging areas of interest in the field of scleral lenses. And finally, we will suggest topics for future study, just in case any of you are attending this webinar primarily to get some ideas for your next research project. So hopefully we're all in agreement as to what a scleral lens is. It rests on the conjunctival tissue overlying the sclera and completely vaults the cornea and limbus, entrapping a fluid reservoir behind the lens and in front of the cornea, allowing that cornea to be continually bathed with fluid. So scleral lens research has really been exploding during the last couple of years. I took a look back through my EndNote library, and in 2013, I identified a total of 30 manuscripts and abstracts on scleral lens related topics. By 2014, there were 43, 2015, 37, 2016, 53. In 2017, there were 83 manuscripts and abstracts published on scleral lens related topics. And in 2018, through October 1st, we had to set a cutoff date for literature that was going to be reviewed at this webinar simply to give ourselves a chance to review it. And I only looked at manuscripts. I did not look at abstracts, but 64 manuscripts through October 1st of 2018. So you can see that the number of publications related to scleral lenses is still growing rapidly. And I'm hoping that you will appreciate, as the evening wears on, the variety of aspects of scleral lens prescription and management that are being studied. Now, as luck would have it, one of the first papers studied, or first papers published this year in Eye Contact Lens was actually a bibliometric study of scientific research on scleral lenses. There's a study of just about everything, and bibliometry or bibliometry related studies take a look at evaluating scientific evaluation activity within a particular subject area. And they utilize some standardized tools in order to do that. Basically, they're asking questions such as how much literature is being published in a given area, what is the geographic distribution of that literature, where is it being published, what institutions are particularly active in publishing this literature, and finally, who are the authors who are publishing in a particular topic. And they applied these research principles to scleral lenses in a paper published early in 2018. So this is just a figure from one of the figures from that paper. And the thing to note here is the blue crescent that represents 40.17% of all scleral lens related literature published from 1962 onwards. There was a 222% increase in this time period, which was 2012 to 2016, compared to the immediately preceding time period, which was 2007 through 2011. So starting in 2012 and moving onward, there really has been a tremendous increase in scleral lens related publications. And this certainly follows our experience as we attend regional and national meetings too. Scleral lenses used to be not nearly as prominent on the agendas as they are right now. Interestingly, a majority of those publications came out of the United States, with a fair number coming out of the UK and some coming out of India. The Harvard Medical School and Boston Foundation for Sight are the top two institutional producers of this literature, followed closely by Moorfields Eye Hospital, where Ken Pullum practices. With regards to authors, Ken Pullum was the most prolific publisher during this time period, followed by Deb Jacobs from the Boston Foundation for Sight and Perry Rosenthal, also from the Boston Foundation for Sight. One thing that the authors of this paper noted was that there was a relatively large percentage of low production authors, meaning you'd get an author who would publish 1 or 2 papers and not really publish any more. And that may speak to the relative immaturity, even now, of scleral lens related literature. Early publications tend to be case reports, and if you are a researcher or a clinician, it's pretty easy to get a case report published without a lot of biostatistical help. Once you get into a more mature research field, it may take a little bit more resources in order to publish, and so those of us who don't have access to those resources would publish the case reports and then perhaps not publish anything beyond that. So study designs represented, we're still seeing a fair number of case reports and case series on unique indications and applications for scleral lenswear. We're also starting to see some case reports and series on complications associated with scleral lenswear. So Mindy's going to go over those in just a bit. We also see retrospective studies on the outcomes of scleral lenswear, both visual and physiological. There are some observational prospective studies, particularly in the area of imaging as it relates to scleral lens fitting, and also related to the impact of scleral lenses on anterior ocular structures. Once a treatment hits reviews of systemic or ocular disease, it almost seems a little mainstream because other researchers who are studying these conditions recognize the value of this treatment modality. And then, of course, there are letters to the editor and various other forms of communication that are published as well.
Here is a listing of case reports and case series demonstrating the shift that Muriel mentioned into unique indications and complications. In 2018, we drifted away from case reports demonstrating how scleral lenses improve quality of life, while moving toward case reports showing complications associated with scleral lens wear. Here's a listing of case reports. Well, let's talk about the benefits of scleral lens wear. We'll start with the obvious, better vision and comfort. The significance of this study was that it was published in the ocular surface publication, not an optometry-related publication, indicating that scleral lenses are becoming accepted by the medical community as a whole. The purpose of this study was to demonstrate patient demographics, fitting indications, and changes in visual acuity in patients' fits, with the pros having irregular corneas as compared to those with ocular surface disease. Prior large PROS studies have largely focused on specific etiologies. This study assessed the visual outcomes of patients with a wide spectrum of disease. Overall, mean best-corrected visual acuity improved across all eyes in both groups. In another study from Egypt, better vision, comfort, contrast, and less glare was found with the ROSE K2 scleral lens design. But what happens when all the patients are fit with a standard edge design? As a result, 4 patients had a complication of a tight edge, which provides better comfort than a loose edge initially, but over time, discomfort and pain will occur. Refitting with an increased edge lift will solve this problem. 6 patients discontinued wear due to persistent discomfort. Ocular discomfort was believed to occur due to prolonged wear time. Hypersensitivity to contact lens deposits, care system, or lens-induced mechanical trauma. This mechanical trauma can be diagnosed by small papillae and hyperemia of the superior tarsal conjunctival tissue. 6 patients discontinued wear due to cost. Cost was an issue since this lens is not covered by government health insurance. 4 patients had handling issues, and with the aid of a special suction holder, were able to successfully handle the lens. Another study from the Vista Group in the Netherlands aimed to evaluate a new mini scleral lens design with a bitangential periphery. The most common reason for fitting patients with a smaller scleral lens design was to avoid sclera irregularities, such as nodules, pinguecula, or other elevations following surgery or trauma, especially when the sclera elevation is away from the limbus. Other reasons for use included reducing debris, providing increased comfort and oxygen, helping with cosmetic differences between the eyes while wearing one lens, and balancing a smaller eyelid aperture or reducing decentration. The least common indication was difficulty handling a larger scleral lens. Horizontal visual iris diameter, or HVID, is useful to measure, as patients with a small HVID make excellent candidates for this design. But this is not the most important measurement, given that patients with larger HVIDs were also successfully fit in this design. As we know, larger lens designs tend to decenter toward the inferior temporal region of the sclera due to differences in the anterior peripheral sclera. Better centration with this design is due to the limbal scleral area, which tends to be more regular. Only 1 out of 133 patients were fit in a rotationally symmetrical lens, while 132 patients were fit in a non-rotationally symmetrical lens. This finding suggests that the sclera close to the limbal area is non-rotationally symmetric more often than suspected. This may be due to non-equal stiffness around the eyes as the sclera settles over time on the soft conjunctiva. Eye muscle attachment is uneven, which may contribute to the non-symmetrical shape of the underlying tissue. When do we need to perform a corneal transplant for keratoconus? This study from Belgium found that scleral lenses actually decrease the need for corneal transplants and that there is no limit in keratoconus whereby a contact lens can be used to treat the eye disease. Even very deformed eyes with severe scarring can achieve functional vision with a scleral lens. This study only included cases of severe keratoconus. Of the 846 patients who were seen in the keratoconus clinic over the 5-year study period, 28 eyes of 25 patients proceeded with penetrating keratoplasty, making the rate of corneal transplant at this clinic to be 1.65%. If the 40 eyes had been included, then the incidence of penetrating keratoplasty within the keratoconus group would have more than doubled to 4%. Can corneal opacities regress over time with scleral lenses? In this PROSE study, 4 cases were presented demonstrating resolution of chronic corneal opacity and improved vision with PROSE treatment. One case was of an 11-year-old boy with an 18-month history of persistent epithelial defects due to a tree branch injury with a diagnosis of herpes simplex neurotrophic keratitis. Initial visual acuity was 2400. He was treated with a PROSE lens worn overnight with prophylactic use of preservative-free moxifloxacin antibiotic and daily removal and disinfection. The persistent epithelial defect healed in 2 weeks with a visual acuity of 20/70, pinholing to 20/50. Another case was of an adult patient with chronic exposure and superficial keratitis associated with facial nerve palsy after head trauma. Regression of neovascularization and decreased opacification was observed after 1 year of PROSE use. Regression continued after 2 years of wear, as seen in this photo. In summary, these cases demonstrated a decrease in corneal opacification with PROSE treatment alone. Can scleral lenses protect the cornea from injury? This case report from the Netherlands shows a scleral lens acting as a protective shield from a high-speed object. The person wearing the lens was a 24-year-old student participating in a scleral lens study. This photo shows the contact lens fragments recovered by the patient. Now we'll talk about complications which are emerging with the use of scleral lenses. We're starting to see cases of graft rejection, edema, microcysts, and keratitis. Graft rejection and epithelial edema can occur with scleral lens wear. The central feature of this case was acute graft rejection due to lens abuse while wearing a high decay mini scleral contact lens, followed by an episode of contact lens-induced epithelial edema 5 months later, primarily of the superior cornea, due to lens-corneal interaction. Superior touch was observed after lens settling. This is supported by the regional nature of swelling and quick recovery of the edema after lens removal. It's been suggested that epithelial bullae and edema in scleral lens wear may be due to mechanical compression rather than hypoxia, since hypoxia-induced edema is stromal in nature as opposed to epithelial edema and takes longer to recover. The recommendation for the corneal edema was to take regular breaks from contact lens wear, ideally every 4 hours, to provide relief for the eye from the sealed lens environment, as well as to avoid excessive lens settling and epithelial insult. The patient continued with the recommended lens wearing regimen successfully, and no graft rejection or epithelial edema was observed at the 8-month follow-up visit. Research from France found that 15 out of 23 patients completed the fitting process using the ICD 16.5 diameter lens. Discontinuation of scleral lens wear was due to difficulty handling, a lack of motivation, or unsatisfactory vision secondary to residual internal astigmatism. 50% wore lenses 10 or more hours a day. In terms of handling, 60.5% had no more difficulty after 1 month. 20% had continued difficulty, and 20% required a caregiver. That was actually 2 children. One complication was observed in this study, and that was corneal graft swelling. One adverse event was observed, conjunctival hyperemia, which resolved by fitting a higher sagittal height lens, and 2 patients developed problems which were deposits between the lens and the ocular surface. This single case report demonstrated improvement in filamentary keratitis over a 1-day period with a complication of corneal edema. As we know, after penetrating keratoplasty, eyes have compromised endothelial cell function. This case report emphasizes the importance of checking for corneal edema with instructions to the patient to remove the lens if the eye feels heavy or colored halos are seen around a light. Pachymetry or anterior segment optical coherence tomography performed before and after lens wear is recommended to measure corneal edema in terms of corneal thickness. To decrease the risk of corneal edema, consider using high oxygen permeable lens materials, decreased lens thickness, minimal lens clearance, and reduced continuous lens wearing period. A topical steroid and a non-steroidal anti-inflammatory medication was added to the tear reservoir, which increased bioavailability of the medication to treat the filamentary keratitis. Corneal epithelial macrocysts can occur during scleral lens wear, but do they disappear over time or cause any contraindications to scleral lens wear? Transient corneal macrocysts were observed in 3 cases of scleral lens wear over a period of 9 years, possibly due to the combination of corneal edema, anatomical alterations after penetrating keratoplasty, and the negative pressure underneath a scleral lens. These macrocysts were located at the edge of the graft and would resolve within 15 minutes upon lens removal. The macrocysts were transitory in nature without evidence of corneal damage or cyst rupture. As a result, the authors feel that it is safe for these patients to continue wearing scleral lenses with routine follow-up. Acanthamoeba. Recently, CNN announced that infections with acanthamoeba have tripled in the United Kingdom since 2011. Just to give you some background on acanthamoeba cases with scleral lens wear, 4 years ago in 2014, we saw a case of acanthamoeba keratitis with scleral lens wear. The risk factors included tap water use and dry eye syndrome, along with its treatment, which was the use of steroids and serum. Just in this past year, there were 3 cases of acanthamoeba keratitis in patients with keratoconus wearing a scleral lens. Part of this study was to find out if scleral lenses pose a greater risk for acanthamoeba keratitis. It was determined that the young age of patients with keratoconus, along with hypoxic changes within the cornea, combined with the large diameter design and minimal tear exchange, can contribute to the risk of acanthamoeba keratitis. The tear reservoir itself turns out to be a perfect environment for acanthamoeba multiplication. All 3 patients in this study did not rub the lenses while cleaning the lens. 1 patient stored the lens in saline solution, another one showered in the lens, and the 3rd was exposed to tap water and topped off the old solution. it was decided that the risk of contamination was due to saline solution. Large amounts of saline solution is used with scleral lenses. Saline solution is not easily available in all countries, so patients may use bottled saline, increasing the risk of infection rather than individual vials of saline. Cost of solutions might be another factor. In terms of cleaning, it may be as simple as the fact that it's easier to clean a small lens than a larger lens. Acanthamoeba can adhere to the scleral lens materials, and rubbing the lens can decrease adhesion of the parasite to the scleral lens. What did we learn? We learned that the use and care recommendations of the care system prescribed should be highly emphasized. I'll put a plug in for the Scleral Lens Education Society. The Scleral Lens Education Society has patient education materials on the website for everyone to use in your practice to decrease confusion among patients regarding care systems. And here's a sample of one of the pamphlets on the website that you can download and use in your own practice. When patients understand the risk of infection and how important it is to take care of their scleral lenses on a daily basis, risk of infection decreases overall. What else did we learn? We learned that preservative-free, single-use saline solutions should be recommended and highly emphasized, and that scleral lenses should be cleaned by rubbing for a minimum of 15 seconds, store lenses in fresh disinfection solution every night, and rinse the plunger with sterile contact lens solution or use alcohol wipes after each use. There were 2 review articles from Current Opinion in Ophthalmology. These demonstrate how scleral lenses have moved into the mainstream of ophthalmology for treatment related to irregular cornea, as well as treatment for ocular surface disease related to lid palsy.
All right, picking up where Mindy left off, there were 2 additional studies that were reviews of systemic conditions or ocular conditions that mentioned scleral lenses. The first was published in Survey of Ophthalmology on Tyrian marginal degeneration. This is a peripheral degeneration, very difficult to treat surgically, and patients who have significant irregular astigmatism have been treated successfully with scleral lenses. And a second study was published in the American Journal of Ophthalmology regarding the treatment of chronic sequelae of Stevens-Johnson syndrome in children. Once things start hitting reviews, it means that they're actually starting to be effective, and hopefully we'll be able to get a little bit more insurance coverage with some of these major reviews mentioning scleral lenses. Jen Harthan and Ellen Shorter also published an article in Clinical Optometry that summarized the therapeutic use of scleral lenses for ocular surface disease. This too may help us get some insurance coverage because it's a well-written summary along with quite an extensive bibliography. So let's talk a little bit about outcomes of scleral lens wear. Well, single center studies tend to use a single lens design and may therefore not be widely generalizable to a population that might be using different lens designs. These studies also tend to focus on scleral lens wear in patients with a particular indication. For instance, they may look at only patients with keratoconus or only patients with ocular surface disease. So they give us good information, but multi-center studies actually give us a little bit more information because even if they use the same lens design, you have different people fitting them. And so philosophies may be somewhat different. There were 2 main multi-center studies published this year. One was for the correction of uncomplicated refractive error, and the second was a cross-sectional survey by the SCOPE study group. So with regards to visual outcomes with small diameter scleral lenses for keratoconus, this group published 2 papers, part 1 and part 2. Part 1 took a look at 27 eyes of 27 patients with keratoconus, And part 2 took a look at 27 eyes of 27 patients with keratoconus and intracorneal ring segments. These studies both indicated that contact lens related acuity was significantly improved compared to spectacle acuity. Contrast sensitivity was improved in patients who were wearing corneoscleral contacts. Higher order aberrations decreased slightly more in the patients with keratoconus than in the patients who had keratoconus and intracorneal ring segments. The only corneal change was in patients who had keratoconus only. There was an increased endothelial cell count, which is somewhat surprising. There were no changes in corneal parameters in the patients with intracorneal ring segments, and no adverse events in 1 year of scleral lens wear in either group of patients. The same authors then published the results of fitting corneoscleral lenses on irregular corneas after refractive surgery. 18 patients were enrolled. 15 patients, or 24 eyes, actually completed the 1 year study. The fitting process was reported. The first lens ordered was the lens prescribed for all eyes. I rather wish that I had that success rate. I don't yet. Mean of 2.9 visits was required to complete the fit. Visual acuity did improve significantly compared to spectacle corrected acuity, and 17 of these original 18 patients reported that the lenses were either comfortable or very comfortable. There were no changes in central corneal thickness, endothelial cell count, or intraocular pressure after a year, and once again, no adverse events were reported. Yet another study from the same journal looked at 40 patients, or 58 eyes, in patients with keratoconus, pellucid marginal degeneration, or post-keratoplasty irregularity. Once again, significant improvements in visual acuity were noted in scleral lenses compared to spectacles. Significant improvement in contrast sensitivity was also noted with scleral lenses. And this is an interesting point. This study was the only study published this year that actually took a look at improvements in quality of life. The researchers administered the National Eye Institute's Visual Function Questionnaire prior to scleral lens wear and then after patients had been wearing scleral lenses for the year. And the mean VFQ score was 52.33 with spectacles. Mean improved 20 points to 75.63 with scleral lenses. And that was a statistically significant improvement in patient-reported quality of life. There was one additional study out of the Boston Foundation for Sight several years ago that also demonstrated a statistically significant improvement in quality of life. As we move towards patient-reported outcomes in healthcare here in the United States, it may not be a bad idea for us to start to administer some sort of a quality instrument simply to demonstrate that our patients who have been fit with scleral lenses do better with the lenses than they were doing with their previous mode of correction. This study took a look specifically at the iPrint Pro therapeutic contact lens, took a look at indications and outcomes. A relatively small study, 10 patients, 14 eyes. A variety of indications for fitting included limbal stem cell deficiency, post-photorefractive keratectomy, decentered ablation, pellucid marginal degeneration, Stevens-Johnson syndrome, keratoconus, dry eyes, neurotrophic keratopathy, and exposure keratitis, along with post-radial keratotomy. The visual acuity improved with scleral lenses to near normal levels. Comfort was also improved in 6 out of 7 previous lens wearers. Of interest in this study, 2 patients, which is a total of 10% of the patients in the study, experienced midday fogging, and that is in line with estimates by Walker, published by Walker earlier. 20 to 30% of patients are thought to experience midday fogging. This is just a brief summary of the patients included in that study. This study looked at the evaluation of large diameter rigid gas permeable lenses versus soft toric contact lenses for the correction of regular refractive astigmatism. This too was a multi-center study. It was a crossover study. 38 patients were recruited. 36 patients actually completed the study. Of those 38 patients, 75 preferred vision with scleral lenses compared to those who were compared to soft toric lenses. Roughly half of them reported an intent to continue to wear scleral lenses. About 40% reported that scleral lenses were very easy or easy to handle, which means that 60% thought that scleral lenses were perhaps not terribly easy to handle, but despite that, over half of them did indicate an intent to continue to wear scleral lenses. Interestingly, there was no difference in objective visual acuity between scleral lenses and soft toric lenses, but patients did prefer the vision with scleral lenses. Corneal staining also showed no difference between the two groups. Bulbar hyperemia, giant papillary conjunctivitis was unchanged between scleral lens wearers and soft toric wearers. The SCOPE study group recently published a paper on the visual and physiological outcomes of scleral lens wear. This study was a multi-center cross-sectional study, and if any of you did the survey that generated the data for this paper, I do want to thank you. We received 292 responses from 26 countries. We asked respondents to specifically describe the experience of a single lens, scleral lens wearing patient, and collected quite a bit of data on that patient. Indications follow what we had known before, with the potential change of even more patients wearing the lenses for corneal irregularity compared to previous estimates. Visual acuity did improve in patients who were fit with scleral lenses for corneal irregularity or ocular surface disease. Patients who were fit with scleral lenses for the correction of uncomplicated refractive errors started with good visual acuity, and so there was no significant improvement in scleral lens-related acuity. 55% of patients exhibited some type of corneal staining prior to scleral lens wear, and 35% of patients exhibited some corneal staining at their most recent visit. Now, interestingly, some patients who had not experienced corneal staining prior to scleral lens wear did, in fact, have some staining at their most recent visit. We also took a look at the number of topical medications used by these patients, and for patients with both corneal irregularity and ocular surface disease, the number of topical medications or agents decreased significantly. We found it interesting to note that even patients with refractive error were using about 2 drops on average regularly prior to scleral lens wear. That number went down to 1.7 drops on average after scleral lens wear. Prospective observational studies have taken a look at a couple of main areas. First of all, imaging in scleral lens fitting, and we'll be going over that first. Hypoxia associated with scleral lens wear is another broad category or theme, as is intraocular pressure is starting to become a bit more interesting with regards to scleral lens wear. And finally, there was a paper published on post-lens fluid reservoir optical density, hoping to give us some sort of a way to quantify post-lens fluid reservoir turbidity over time. If you're going to read one paper on anterior segment imaging and scleral lenses, this is the paper that I would recommend for you. It is a very well-written, comprehensive review of the use of anterior segment OCT in scleral lens prescription and management. The study takes a look at the definition of anterior segment anatomy and morphology as related to scleral lens wear, things like corneal thickness, scleral thickness, curvature, corneoscleral angles, sagittal height or elevation. The study also suggests that scleral lens or that anterior segment imaging can be used to assess scleral fit in measurement of peripheral and central clearance, assessment of settling, haptic or landing zone alignment with the conjunctiva, as well as lens decentration. Imaging also allows for a facilitation of follow-up and lets us measure changes in the post-lens fluid reservoir, lets us measure changes in the cornea. Perhaps the most useful thing about this paper, besides a very well-written summary, is the fact that the bibliography contains over 110 references. So if you have any other interest, my guess is that you could probably find a reference that would match that interest in that bibliography. So taking a look just briefly at some of the studies that have been published that have looked at corneal topography and how we fit scleral lenses. This study took a look at 126 eyes and basically measured estimated height chords. They found that these chords correlated with scleral lens sagittal depth. They also found what we have suspected from previous studies, in that corneal toricity was a poor predictor of scleral haptic zone toricity. So the cornea and the sclera don't appear to have the same amount of toricity or in the same orientation. This study took a look at anterior scleral shape and identified several different types of relationships between the cornea and the scleral curvature, discovered that, again, as we had suspected before, the smaller diameter chords showed more symmetry than chords that were farther from the limbus, and also showed flatter angles in the nasal compared to the temporal quadrants. Dottie Fidel published several papers on the influence of scleral and limbal shape on scleral lens design and the fitting relationships and problems that can arise from fitting that don't match, fitting haptics that don't match the anterior curvature of the cornea. This was a very interesting paper that took a look at anterior segment OCT angiography to assess peripheral fitting of scleral lenses. If any of you attended the scleral lens super session at Academy, similar study was presented there. Blood flow through the conjunctival vasculature can be imaged using anterior segment OCT angiography, and can therefore show in real time the amount of compression or impingement of vascular tissue by the lens haptic. This study took a look at changes in anterior corneal curvature and aberration after scleral lens wear in keratoconus patients. The study showed a few changes in the shape of the cornea after scleral lens wear. As was reported by the Visser group, generalized flattening of the cornea was noted, most pronounced in the supranasal quadrant in some of the patients and in the inferior quadrant in patients with intracorneal ring segments. There was a general reduction in higher and lower order aberrations in all subjects. This is a companion study to the study just mentioned. This showed that there was actually a reduction in corneal thickness with scleral lens wear, about 2.03% in keratoconus patients, 2.77% in ICRS patients over the course of 1 year of wear. There were no changes in anterior depth. No consistent changes were noted in posterior corneal curvature. This study looked at corneal changes after 5 hours of scleral lens wear in healthy patients, and during the 3 hours immediately following lens removal, no significant changes were noted in corneal parameters, but there was a flattened scleroconjunctival contour, which didn't recover during the 3 hours after lens removal, which mirrors a study by Vincent that was published, I believe, last year. Now we're going to move on to the oxygen question in the final several minutes here. So the theory is that scleral lenses may cause chronic hypoxia if the lens or fluid reservoir thickness is excessively thick. The literature does not show a large number of hypoxic complications, although I personally suspect, and this is opinion here, that complications associated with scleral lens wear may be underreported. However, there is some nuance. Regional lens thickness needs to be considered as along with lens flexure. What happens to corneal thickness over time? Do you get tear exchange or tear mixing behind a scleral lens? And this is a really interesting and very active area of study right now. There have been quite a number of papers published on this topic. So Vincent and company, the same individuals who wrote that lovely review on anterior segment imaging in scleral lenswear, utilized high-resolution imaging to take a look at scleral lens thickness and came up with something that we all know to be true, that lens thickness is at least in part dependent upon the position at which you measure the thickness. If you've got a high plus lens, you're going to have a thicker center thickness than you would if you've got a high minus lens. So there is considerable variability in thickness profiles between different lens designs. So perhaps an average lens thickness might be a better value to use when modeling oxygen transmissibility than the center thickness. They then went on to determine that lenses that were quite thin were more likely to show some flexure, particularly in the cases of individuals whose sclera showed more than 200 microns of toricity. And this also makes sense. If you've got a very thin lens, that lens is going to be more able to flex. So they took a look at 150, 250, and 350 micron thick lenses and discovered that the 350 micron lens was considerably less likely to flex than the 150 micron lens. This study also took a look at the epithelial as well as stromal edema during 8 hours of scleral lens wear. Corneal thickness and stromal thickness tracked pretty well, and so it appears that most of the thickness change that we get with scleral lens wear is in fact stromal thickness. However, the interesting thing in this study is that it peaked after about 90 minutes of lens wear and then started to decrease slightly after 90 minutes. Epithelial thickness increased during the first 30 minutes and then decreased afterwards. Greater initial corneal clearance did decrease oxygen supply, but it only resulted in 0.5% of difference in corneal thickness increase. So why is this? Well, Pa took a look at the amount and percentage of exchange that we get under silicone hydrogel lenses and rigid gas permeable scleral lenses. Utilized fluorophotometry to take a look at these two values, found significantly lower percentage of elimination rate with a well-fit scleral lens compared to silicone hydrogel lenses over 60 minutes of wear. Now that percentage is interesting because the volume of tears behind a scleral lens is considerably higher than the volume of tears underneath a silicone hydrogel lens. So it's possible that the volume of exchange would be comparable, but the percentage was much lower with scleral lenses. Kim and company, Meng Lin study group at Berkeley is also taking a look at some other factors that may relate to corneal hypoxia with scleral lens wear. They took a look at transfer resistance modeling and applied that to oxygen transmissibility and carbon dioxide permeability in addition to post-lens fluid thickness and scleral lens thickness. And the theoretical models and clinical observations suggest that increasing the post-lens tear film thickness from 50 to 400 microns really doesn't have an awful lot of an impact on corneal edema in an open eye state. In a closed eye state, that did become significant. This was a clinical study taking a look at tear exchange beneath a scleral lens in 5 hours of wear in neophyte scleral lens wearers. The time course of the corneal thickness change mirrored that of Vincent's study. The cornea got thicker for about the first 90 minutes and then stabilized or even decreased in thickness. Of interest, there wasn't a relationship between the thickness of the post-lens fluid reservoir and corneal swelling. So it appears that there are some more questions to be answered regarding corneal thickness changes and the thickness of the post-lens fluid reservoir. Several years ago, Dr. Now and I published a study that took a look at changes in intraocular pressure associated with scleral lens wear in young healthy individuals. We found no difference using the new tonometer. The most recent publication by Michaud and company showed that with the diaton tonometer, which is a transpalpebral tonometer, scleral lens wear did in fact statistically significantly increase intraocular pressure. So this now becomes an area of interest. I'm always most interested in that juncture between what we know and what we really don't know. And intraocular pressure is one of those things that we really don't know. Dr. Now and I also published this study earlier this year. If you are wondering how to assess the turbidity that your patients are experiencing during scleral lens wear, it's pretty easy to do it if you've got a pentacam. You don't have to count cells or anything like that. You just have to take a look at the optical density graph that is on the right side of the Scheimpflug images, and that will tell you the change in the turbidity or the optical density of the post-lens fluid reservoir. This may be interesting in patients who are highly symptomatic. I don't know if you have noticed this or not, but it seems that some patients with minimal fluid reservoir debris are highly symptomatic, whereas others that have very milky fluid reservoirs are really less symptomatic. So this is certainly a question that needs to be answered, but this may be one way of actually quantifying that fluid reservoir turbidity change with time. Stephen Vincent wrote a very nice editorial for Contact Lens and Anterior Eye that took a look at scleral lenses and orthokeratology as driving a resurgence in interest in rigid gas permeable contact lenses. And then I can't omit the publication of Contemporary Scleral Lenses, Theory and Practice, edited by Melissa Barnett and Lynette Johns. This book was reviewed by both A. Vanderwerp and Ed Bennett, and really does represent a tremendous addition to the scleral lens-related literature for the year. The motto for the year, the more we learn, the less we know. So questions to be answered in coming years: what exactly is the role of imaging in scleral lens prescription and management? Is imaging just for answering questions related to research, or is imaging absolutely necessary for clinical care of these patients? Patient-reported outcomes, I think, need to be studied in greater detail. Scleral lenses can do wonders for patients, but we do need to know what patients are thinking of these lenses and their impact on the quality of life. Corneal edema and corneal hypoxia are still huge questions. What do we need to consider in addition to decay? And finally, I think we do need some data on long-term implications of edema that have been observed with scleral lens wear. We also need to take a look at long-term patterns of edema. Does the cornea just continue to swell, or does it stabilize and reach a new steady state with scleral lens wear? There's just a lot that we don't know. And then we really do need to study the implications of scleral lens wear on intraocular pressure as well, to determine which patients may be at risk for elevated IOP with scleral lens wear. And then a very simple study might be to determine the incidence of glaucoma in scleral lens wearers and compare that to the incidence of scleral lens or of glaucoma in the general population. So those are just a few of the things that I'm interested in taking a look at as the years go on here. So with that, I'd like to wish all of you a very happy holiday season, and thank you so much for joining us. If there are any questions, Andrew will be back on and we can moderate those. Thank you.
All right, thank you very much for a wonderful talk. Considering the time we have left, we'll probably have time for one or two questions. Anybody else who asked them, though, we will definitely respond to those via email afterwards. I just want to remind everybody that this course was COPE approved, so you will be getting an email in the next day or two, and that email will have two links. One will be for a survey about this course and what you'd like to see in future courses. And then it will also have a link to a quiz, which you can fill out and have to achieve 70% on to get COPE credit. It then takes about 3 to 4 weeks for the COPE credit to be uploaded to ARBO. It's just a heads up on that. We've probably got time for one question here, so I'll ask the first one. What would be the recommended corneal clearance on the average scleral lens patient to prevent edema?
I'm not sure we can prevent edema with scleral lens wear. I think that question has yet to be answered as far as literature goes. If we take a look at earlier studies, the recommendation was to minimize corneal clearance, but we do know that scleral lenses can settle over time. And so a lens fit with 100 microns of clearance today may actually be resting on the cornea, or may have 30 microns of clearance 6 months from now if the conjunctival tissue and episcleral tissue becomes compressed. So if we take a look at Meng Lin's study, they suggested that anywhere from 50 to 400 microns of clearance may be acceptable. We also took a look at what patients were, or what people were actually doing with the scope survey, and found that most folks were comfortable with up to 300 microns of clearance. But again, that question has yet to be answered in any sort of a rigorous research way. It could depend upon the cornea we're talking about too. If you've got an elderly patient with a low endothelial cell count, that could play a role. Maybe you want a little less clearance there or more exchange. If you've got a patient who is young and they have a nipple cone with Ks of 72, you're going to have a little bit more clearance around the peripheral cornea just in order to clear that center. So very good question. Sort of waffle, but I don't think there's a very good answer just yet.
Well, again, thank you both so much for a wonderful presentation. Everyone, keep an eye out next year. This is the last Scleral Lens Education Society webinar for 2018. We'll have a new slate coming out for 2019. So keep an eye on the new scleralens.org website, the Scleral Lens Facebook page, and obviously we will blast it out via email. So happy holidays to everyone, and we will see you in 2019. Thank you, guys.